Okay, folks, we're going to get started with our last session of the day. We're going to begin with our keynote presentation. Our keynote speaker is someone I learned about in the last year, first by watching a masterclass by the famed author of many movies and books, including Moneyball, The Blind Side, The Big Short. His name is Michael Lewis, and in his masterclass on writing, he talks about several key characters in his books, one being his book called Premonition, which is about the backstory of what happened during COVID. And one of his characters is this brave young woman, Dr. Charity Dean. And I became interested and captivated by this person when he told this story.
Pandemic was that we had these characters in this country who knew how to manage disease spread. They were called local public health officers. They were not called the CDC. They managed disease outbreaks, measles, tuberculosis, whatever it was, on the ground in real time and had been doing it. But they were these lowly bureaucrats that no one paid attention to, yet they had this expertise. And Charity Dean was the top gun of local public health officers, but no one knew who she was. I needed her to just pop. I needed people to say, oh my God. And she did as a real person. So it opens with her faced with this dead body that has tuberculosis in it. And she needs to find out if it's in the lungs, because if it was in the lungs, it had the capacity to spread to other people. To get to that lung, she needed to saw the body open, and nobody would do it. Not the coroner, not doctors. Everybody thought it was too dangerous that you cut open a tubercular body and you might get tuberculosis yourself. There wasn't a whole lot of evidence for that. Point about Charity is she wasn't afraid. And the scene ends with her outside the county morgue, which is a crappy little building on the side of the interstate with a picnic table in the dirt outside, with this body on top of that picnic table and a bunch of men in hazmat suits because they're afraid to get near the body, and Charity in cutoff shorts and a tank top, and given no instruments to cut the body open, grabbing a pair of garden shears and cutting this woman's body open, reaching in, grabbing her lung and tossing into a bucket and riding off while the men kind of just melt. And that was going to establish this person.
Yeah, anyone who knows that whole story, and that happened in Santa Barbara County, one of the richest counties in California, where she was the public health officer. As she'll explain to you in telling her story, she's a diverse in her training. She's quite smart, quite aggressive. She's fearless. And I asked her to come and talk about reinventing oneself. Let's listen to Dr. Charity Dean. She's going to answer questions at the end of this address, so please feel free to put them online, and we'll engage her in conversation as this ends. Dr. Dean.
Hi, this is Charity Dean, and it's a huge honor to be invited to speak today to my tribe, which is a tribe of doctors and medical professionals. When I was asked to speak with all of you, my first reaction was, what an honor, because it has been 4.5 years since I left my role as one of the lead physicians for the state of California, leading public health during the COVID-19 pandemic. And I've put my head down and been pretty quiet about what I'm doing, and have not yet had the pleasure of speaking to physicians, MDs, those that treat patients, that put their hands on the patients, wear a stethoscope every day. In the world I'm in right now, I interact more with policymakers and technology. And so what I'm going to share with all of you, and this is going to be pretty raw, honest, and vulnerable, is a little bit about my path and how I've reinvented myself, and maybe more accurately, the superpowers, including the dormant superpowers that we have inside of us. How are those coming out and reinventing what we offer to our patients, to the world, to public health, to healthcare, in the age of a total technology revolution? To begin with that, I'll just kind of set the frame of who I am and what I'm doing right now. I'm a doctor's doctor. I was a poor kid from nowhere that clawed my way out of a pretty rough upbringing, meaning, not a family of means. I earned a full ride scholarship to college. And from the time I was a little girl, I was just obsessed. I was about 7 years old when I became obsessed with infectious disease, and not just the normal stuff, not, influenza or respiratory viruses. When I was 7 years old, I heard a missionary come to our church and speak, and she was coming from West Africa, and she was talking about hemorrhagic fevers. And I remember going home that night and deciding, I'm going to become a doctor, and I want to study communicable disease and the bloody, spooky, scary stuff. And I want to be right on the edge of where those diseases are emerging, eye to eye and nose to nose with the patients, with the technology, because I thought something big was coming for the world. And I just became obsessed with it. My career led me to become local health officer. And I started out doing trauma surgery. To be honest, those of you that know Norm McSwain, who was a very well-known trauma surgeon at Charity Hospital, Tulane, where I trained, was one of my mentors in medical school. And I was categorical general surgery, and I loved trauma surgery. And Norm McSwain taught me how to think in a very fast, probabilistic differential diagnosis branching algorithm. And when I made my way to public health and became the local health officer of Santa Barbara County, with the background in surgery and with an obsession with the spooky biological threats that could emerge anywhere in the world, here was kind of the thinking, the mental algorithm, if you will, that I had been trained to think in by internal medicine, by infectious disease, and by Norm McSwain and trauma surgery. Scattered clues or social history of the patient, contextual information from where they were coming from, a list of lab results that may come back, an X-ray that you think you want to redo. Scattered clues in time and space led to a differential diagnosis of you're going to treat for the most likely community-acquired pneumonia, but you're going to mitigate for the less likely but catastrophic that's on the bottom of that list, let's just say anthrax. And so that differential diagnosis with an assigned probability to each thing on the list and the branching algorithm, the if-then, that came off of each one of those items on the list, that's how I started running disease control at the county level as a local health officer. The difference in me, the difference at the time was that as a local health officer, I had very few resources. I had a clipboard, I had sticky notes, I had a whiteboard. I had an awesome county clinic lab where we were just starting to do genomic epidemiology, and I could run 3 stories down county clinic from my office in disease control down to the lab to look at the rabies smears, to actually look at the genotype myself of the tuberculosis bug that was in a family I was treating. And then I'd put it on a sticky note and tape it on my wall. And what was I really doing as a local health officer? Well, number one, I was responsible for the risk management of the entire population. And when I became state health officer of California, that's 40 million people, sounds like a bigger job. It actually wasn't. It was that same risk management of a population based on a differential diagnosis and a branching probabilistic algorithm. Mitigate the catastrophic, treat for the most likely. I know I'm talking to a room of doctors, so nothing I'm saying here is new to any of you. Why does this matter? I'll tell you a story, and this is going to get to the superpowers that we have as doctors inside of us. The way that we have been trained to think is actually what the AI machine learning technology revolution needs right now. In January of 2020, I found myself as the number 2 at the state of California and trained my whole career in communicable disease, pandemic level threats, making fast decisions on behalf of not just a state, but California, oftentimes leads the nation. When the very early clues started popping up that a new and dangerous respiratory outbreak was coming from Wuhan. The clues were patchy and scattered through a network of information, my physician colleagues, my public health colleagues, and just getting on the phone with folks that were starting to see early cases. It was actually pretty darn clear in January that the course was inevitable towards a global pandemic, and that this was respiratory, this was airborne. There was a component of asymptomatic spread. And we didn't know how many undetected cases had already entered the United States, but we knew it was high enough that quick action would be required to contain it. That differential diagnosis and probabilistic thinking led me to map out on a whiteboard with what I would call third grade math, the attributes of the virus. And when I say attributes, I mean, the infectious period, the incubation period, the R naught, and you just take those attributes and you math them out with third grade math of what direction is this going to follow. And I stood back. This was around January 10th. And I didn't believe my own math. And so I did it again. And then I did it again. Anyone who's ever been in that situation with mapping out probabilities based on attributes of a contagion knows that our tiny human brains, at least my tiny human brain, struggles to comprehend exponential growth. And the gift of that moment is I was not alone in doing that math. And if you're familiar, if anyone's read the Michael Lewis book, The Premonition, where he tells some of my story, there were many people doing that math, looking at the attributes of the virus. The challenge of the moment was this. There was no way that either doctors on the front line that I was talking to on the phone, or those of us looking at the scattered clues across time and space and applying our mental model of probabilistic thinking and if then, and here's the fast actions that need to be taken. There's no way that we could have done that together without a shared intelligence, without a common operating picture. The old way of doing stuff, the kind of antiquated legacy approach, and we all know this, is got on the phone with the ER docs I know and walked through that with the trusted tribe of doctors who were all speaking behind the scenes, trying to come up with a mental model of the direction this would go. We know how that story ended, and quite frankly, I don't even want to talk about it. We're all scarred. What was really hard for me, and the lowest point in my career, quite frankly, which I don't know that I've ever even publicly spoken about, was by June of 2020, the sense of total failure. That this was the one thing I'd trained for my whole life, and yet America had failed in the response. And the doctors and the healthcare workers were the heroes on the front lines of it. But the system had failed. The system, we didn't really have a system. We didn't have a way to connect all of the frontline healthcare workers together in real time. We didn't have a way to look at a source of truth. Simultaneously, and this is where sparkly hope comes in, watching the technology revolution and watching that machine learning algorithms can be applied to data and the direction that whole sector was going. I realized that, oh my God, here we sit in the middle of this technology revolution where, 22-year-olds in Silicon Valley who are wizards at coding machine learning algorithms, and this was 2020, are building out a new kind of capability. And would it be possible? What would happen if the probabilistic branching algorithmic thinking of a fast surgeon's thinking, of a trained internist who's used to applying that to patients every day, what if that was applied to health security at large or public health at large? And is it true that us as doctors are uniquely wired for the AI revolution? I did not think I was smart enough to do that or to figure that out alone. But I jumped off the ladder I was climbing in government public health and jumped into Silicon Valley to figure it out and started building the platform. through fits and starts and zigs and zags. And here's what I have learned the last 4.5 years, because today I'm the CEO of a defense tech, biodefense, intelligence company. And we deliver that intelligence through artificial intelligence and machine learning algorithmic approach layered on top of metadata. But let me tell you something. It is so intimidating when we as physicians look at how fast the AI revolution is moving, and that large language models and fine-tuning algorithms around the edge of those will be able to push out, a corpus of intelligence that will supplement, replace the role of a healthcare worker or a smart, what I would call the gray matter intelligence that sits on top of AI and on top of data. And I hear that fear all the time of, especially from, my tribe of physicians, that we have been trained to do something really well. We put our hands on the patients. We know how to approach primary care and primary diagnoses and a differential workup. Is the AI revolution going to harm this trade that we love and our trade craft of medicine and putting our hands on the patient? Here's what I would say. You want to know a wild secret? I feel like I'm sitting on this secret inside of AI and defense tech in Silicon Valley. All of the tooling and all of the, I'll speak in software language of anomaly detection through layered metadata to correlate in time and space by machine learning rule sets, an event detection that can back propagate through signals or forward propagate to make a prediction. You want to know a secret? All of that is literally the way a doctor's brain is wired. And the most powerful thinking and thought partners to me on this journey have been physicians. We are literally wired to think in the way that AI is being built. And if doctors sit on the sidelines, if we opt out of the AI revolution, no offense to the 22-year-old software engineers in Silicon Valley, but they do not know how to build. They cannot possibly build the value creation that we can in medicine when we jump into the flow of AI and machine learning. It feels like I'm sitting on a secret only because I've been shocked to realize it's kind of the emperor's naked type moment, that as new large language models come out and as new AI models come out, and anyone that's been following what's happened with the news about DeepSeek in the last week, hugely relevant to the work that I do, but to all of us, doctors got to get in the fight and get in the game. And I can share a few more stories from the world that I'm living in right now. We can talk about scary hemorrhagic fever, what's happened with Marburg, and the different outbreaks that have emerged in Africa in the last 12 months and happening now. All of the intelligence that's coming from that is, number one, doctors at the bedside and doctors on the ground, and scattered patchy information through a healthcare system. But layered around that is what I would call the social history. Dr. Jose, who was my mentor in infectious disease, said to me when I was a young energetic resident in internal medicine, he said, Charity, in infectious disease, the most important part of the medical history is not the medical history. It's the social history. It's not the objective criteria of all the things you're going to go through in surgical history. It's actually, where have they been? Who have they had sex with? What are they smoking cigarettes? What substances are they using? And especially in communicable disease, what congregate settings and who are they, let's just say, cross-pollinating with? What is wild about looking at something like generating large-scale intelligence on Marburg outbreaks in vast geographic regions of Africa, it is exactly that. You have the objective data or the healthcare data, but the social history or the contextual data around it, human mobility, consumer data, local news outlet, what are the cultural considerations on the ground, and what are people worried about? How is travel shifting? How is mobility shifting around that? Remarkably, that approach of objective data at the center, or the layers of data, and back propagating through those signals, and you wrap the contextual around it. You guys, it is everything that a doctor does at the bedside with a patient when they're trying to figure out the diagnosis. And here's what I'll say about the true kind of national security, global security situation that we're in right now as a world. Never before in the history of humanity, and certainly not in the history of physicians, and I would argue public health is the history of the world. It is the oldest story in the world. Never before have we been in the situation we are today, where because of artificial intelligence and because of the ubiquitous availability to anyone in the world, including bad actors, of AI tooling, information, the recipe to make biological threats or bioweapons, never before has the entire biosphere been modular components that can be artificially rearranged, combined into entirely new biothreats that we have never seen before. What I'm talking about is nefarious biological engineering. Part of my story is my obsession with microbiology and genomic epidemiology. My deep domain expertise is actually in multi-drug resistant tuberculosis and the single codon mutations that are carried through a population and code for rifampin resistance and MDR, moving towards XDR, TB, and how do we track those codons through a population? Fast forward into the AI world and the tooling that's ubiquitous globally now, the kinds of good tools or biotech developments that would be used for that exact kind of science now today are available for darker purposes. And in this biosphere where the whole world is modular components that can be artificially rearranged, what the world needs and what the US needs is the ability to very early on detect through metagenomics and other targeted methods the emergence of spooky biological threats that I only fantasized about as an undergrad studying microbiology, because today all of those are possible. The unique thinking of that I've applied to solving this problem through software, and I work closely today with the Department of Defense, and it's an honor to have earned that right, and expanding for national security. The thinking that I've applied to solving this problem, again, is a doctor's thinking of components of a disease or signals or clues that pop up, and that might be in a genotype, may not be in a phenotype. Detecting that very early on into a differential diagnosis of probabilities immediately leads to an action list, meaning, so what? So what does it mean for this patient? What does it mean for this population? Are we going to reverse cordon a whole city? Are there medical countermeasures that need to be deployed immediately? Are we looking at a novel infectious agent that was introduced multiple times into a population? Or was it a single introduction that spread? What I'm getting at there is the utility of a doctor's lens on phylogenies that translate into actual tactical, practical decisions on the ground. So mixed in this soup is genomics and microbiology and the clinical instinct of a physician looking at symptoms that maybe those symptoms shouldn't run together, but they do. In the inflection moment the world stands at today, where sure, naturally occurring threats we worry about, like Marburg outbreaks emerging in Africa and early detection of them. But there is now a much darker realm of biological threats, and it's something that I'm extremely focused on, where the birth of AI and all the gifts that we have from AI and biotech revolution have also led to this darker realm. We cannot fight that fight without doctors in front, without doctors at the helm, without the thinking of a shrewd, trained, seasoned physician who their whole career has been at the bedside and understands those probabilities. America won't win that fight, and the kinds of pathogens that are coming, and I believe far worse than COVID exists and far worse than COVID is going to come our way. in the next few years, and may God help us if we're not ready with the kind of intelligence capabilities we need by then. But doctors have to lead that fight. And if we, and I'm speaking for myself here, because there's moments where I'm super intimidated by the technology revolution. If we cede that leadership role to just the software engineers and just the data engineers and just those that are building and coding the AI models, then we've ceded the very heart and soul of biological threats. We've ceded the very heart and soul of caring for a patient and then a community and then a whole population. I believe doctors should be leading national security in the biological threat space. And I would love, I love every time I see more docs getting into the fight. But I would love to see doctors leaning into the AI tooling, and not just in the biotech medical countermeasure, what new monoclonal antibody development is going to work against emerging disease, but actually in the technology, machine learning, AI development, because it is actually our thinking. It's our genotype, if you will. And forgive me for using that metaphor, but our genotype of being trained as a physician is going to emerge throughout our careers as different, phenotypes, if you will. In my 30s, I was a local health officer, and I was running up and down stairs down to the microbiology lab, looking at communicable threats, biological threats, white powder, chemical, you name it, that were facing my county or my state. And I was doing it manually with sticky notes and a whiteboard on a wall. I was on the phone. There was no technology. I struggled to even use spreadsheets at that time. That was 2014. My phenotype shifted, into my 40s of leading a whole population in the state of California and having more technology tools available. In the last 2 years, with the ubiquitous availability of not just things like ChatGPT and large language models, but the efficiency of the algorithms and how fast they're improving it, efficiency to use less compute power. The world stands at this inflection moment. And, my phenotype today is I'm a tech CEO, leading the fight for biodefense, the United States of America, and building out that new tooling that will be needed for the benefit of all. If there's any kind of encouragement, I would hope that, and I don't know how my story ends, but the end of my effort or the end of my life would simply be, as a doctor, if you slice me open, that's who I am on the inside. As a doctor, was I able to, with vulnerability and how hard it is to learn a new trade craft, was I able to reinvent myself to keep up, not just keep up, but lead the technology revolution to ensure that the thinking of a shrewd bedside physician, the instinct of a differential diagnosis, when you include something on the list and you can just smell that diagnosis there, that the scar tissue of decades and decades of actual frontline practical experience, was I able to apply that to lead the technology revolution? The tooling that we're going to see in health security and intelligence is going to entirely displace the old legacy approach that we have used of doing things for health security, for biological threats, for public health, for healthcare systems. And if we're able to jump in and not just keep up and read about it on the side, but actually lead that revolution, I believe the potential of that for the good of humanity is massive when doctors lean in. It's really tempting for me right now, working in the field that I'm in, kind of the intersect of intelligence and biological threats and medicine and actual differential diagnosis for a population. It's really easy at times to get intimidated and to sit out. And I've got 1,000 examples of that. Whiteboarding the product architecture from scratch, or looking at structured and unstructured metadata, and some of the things that wizard software engineers or data engineers are really, really good at and have trained their whole career for. But every time I ask myself that question, who do I want to be in this moment? And I think back to gross anatomy. I went to Tulane for med school, and I remember memorizing the venous system, in purple and red and blue, and laying those on top of each other overnight. And one night, the arterial and venous system and the portal system, and sitting back and saying, it's a system of systems. Okay, so we're trained to think, doctors are actually trained to think in a system of systems with a probabilistic differential layered on top of it. Let me tell you something. All of the technology revolution and the machine learning tooling and the large language models and the exciting stuff that's coming out as a result of the DeepSeek news last week, all of it is system of systems thinking, all of it. And very specifically when applied to health and healthcare, that's the secret, that it's actually a doctor's brain at the core of it. You are uniquely wired to get into the build, to lead the mission in whatever area you're working in. And I think that you'll discover it as you do that, like I have, that the system of systems of inputs and algorithms and contextual information and sorting based on rule sets and the outputs is, for me, it's literally no different than treating a patient in county clinic, than sitting with my favorite MDR tuberculosis patient in the bottom of county clinic, eye to eye and nose to nose, no tooling, no resources, no AI tooling at my fingertips. The thinking and mental approach that any one of us would use in that situation is actually exactly what's happening right now in the technology revolution. Now, 22-year-old software engineers won't use those words, and they don't have to. That's fine. But I use those words, and that for me has been this joy of taking on an entirely new phenotype here in my 40s, to lead the same old thing, preserving and protecting America and communities against the kinds of spooky biological threats that are coming. And at this inflection moment, where the whole biosphere is modular components that can be artificially rearranged and redesigned by nefarious purposes into biological agents never seen before and difficult or impossible to detect by the old legacy approach. Our willingness, the willingness of actual frontline practitioners to get in this fight and lead this fight and get right at the center of the technology revolution, I am convinced that will determine the outcome here. And that's what I'm doing with my life. I'll briefly touch on the book, The Premonition. When Michael Lewis came and found me and I was leading the state operational response for the state of California, I thought my job was to teach him public health. And he was the worst student I'd ever had. And I didn't know who he was. And we started working together, and he started kind of following me around, and he'd come to my house and I'd map out for him an AFB smear when you're trying to diagnose tuberculosis and what is 4+ versus 1+. And it was so difficult trying to teach him that I literally tried to fire him multiple times. Now, if you know Michael, if you've ever worked with him before, he has the biggest heart and the best sense of humor. And he would say, no, don't fire me. Teach me again. And so through 2020, I thought my job was to teach him microbiology, public health, and biological threats. I did not know that I was the main character of the book. And I did not read it until it came out. And I was horrified, absolutely horrified. I was mortified at how true it was, and that he told my life story. And Michael told stories that had never been told before about my path to becoming a doctor and what it was really like inside the public health machine, and how broken the system really was, and how frustrated I became. And I gasped when I read it. He titled the whole book The Premonition, and that annoyed me too, because that was a very personal thing. I'm speaking to a room of doctors, so I'll end with this. The sixth sense of a doctor, or what I would call the higher level knowledge that comes from consciousness, when sometimes we just know a diagnosis and we put the pieces together and our intellectual intelligence can say why we think that's it. but there's something else there where our intellect makes this leap, as Einstein had described, and we don't know how or why, but we know what the diagnosis is and we know what's coming. That only comes from a trained muscle memory, decades at the bedside, decades in the area of our expertise. For me, that's communicable disease and biological threats. You can call it a premonition. I don't like that word, and I was annoyed he named the book that. You can call it an instinct, but the tuned, trained instinct of a domain expert, very specifically a doctor, I would trust any day when the data is scattered and patchy and early. And that's the story Michael told in the book. And I guess I always hoped that when a physician read it, they would ignore kind of the shiny seduction of that word premonition, and they would see between the pages of my story the hard, gritty path that we take to earning the right to have a very strong sense of what's coming, the ability to predict, the ability to come up with the right probabilities. And at the end of the day, it's something that's just unique to physicians. It's just a unique role that physicians play. We play it in our communities. We play it with patients one-on-one. And that is where I believe physicians should have a leadership role in the AI revolution, biological threats, and the fight that I believe is coming. And that's what I've dedicated my life to. I'm going to stop there because I know that we're going to do a Q&A session, and I'm really excited to hear from all of you and answer whatever questions I can about my path or the AI revolution. And I hope that any parts of my story are useful to you. Thank you.
Okay. Dr. Dean, so good to see you. Great presentation. We've got a lot of questions. I want to start by, you're saying at the end that you were mortified by that book when you first read it and by what Michael Lewis did in making you the main character. It was all about you, and he basically opened up a big old can of vulnerability. What did that do to you as far as what came next? Was that a defeating thing, or was it inspiration for you to make this new career change into bioterrorism?
Well, it's an honor to be with all of you today. Thank you. It's truly an honor to speak to a room full of clinicians. I was so angry at Michael Lewis that I would not speak to him for 2 weeks when I first read the book. And it was about to hit the shelves. It was hitting the shelves in, I think, 10 days. And I was so mad at him that his daughter Dixie had to intervene and negotiate a truce between us, because I was ready to say, to heck with this. I don't want to be part of the book tour. I don't want to have any part of this because you just told my true story. And especially as a government health executive, I had worked so hard to get to where I was. And no one knew that I was a poor kid from nowhere. No one knew that I'd had to claw my way out of poverty or what it took for me just to become a doctor. And I never wanted to, I guess, show that vulnerability, wear my heart on my sleeve. So what it did for me, after I got over being angry at him, and tragically, his daughter Dixie was killed 3 weeks later in a car accident. And that was incredibly, incredibly difficult. It's one of the reasons why there was not a big book tour or publicity. Obviously, everything changed for Michael Lewis. What that did for me, having the story told so honestly, was kind of a permission slip. The public vetting of my life is out there. He went through everything. He hung all my dirty laundry out in that book. The worst, most humiliating moments of my life, the greatest failures, my frustrations, and my honest perspective on the Centers for Disease Control is written on those pages. And so it became a permission slip for people to understand my heart motives and who I was. I didn't have to explain myself anymore, if that makes sense. I had already decided, I knew at that point when I was working with him that I was going to leave my role in government. I didn't want to, but I had already made that decision. It was the hardest decision of my career. And so by the time the book came out, I had already left my role serving Governor Newsom and was in the very beginning stages of learning, how do I build machine learning AI software for biological threats? And that too was a total hero's journey that is not captured in the book. The book really ends with when I left government and was making a decision of what to do next.
So reinventing yourself is scary. Are you at your best when you're in or outside of your comfort zone?
Oh, I hate being outside of my comfort zone. Could we just nestle up in this warm, cozy cushion of our comfort zone? Someday I'm going to find a comfort zone and just live there. I guess that answers your question. Here's the problem. Humans do not grow inside their comfort zone. We only grow when we're being challenged, when we're challenging ourselves, when we're deeply uncomfortable, when we're insecure, when we're vulnerable. And for whatever reason, I continue to pick the path that is deeply uncomfortable over and over and over. And I'm reflecting on that today. Sometimes I question my life choices and yearn for, the happy comfort zone. My comfort zone, it was serving tuberculosis patients in county clinic. It was being local health officer. It was being nestled within the community that I love. But the problem with that is that's the place where I gained the insight that the U.S. public health system is broken and a new kind of technology is needed.
So we have a lot of questions about bioterrorism, a lot of questions about COVID and the beginnings of COVID. So you, as a public health epidemiologist person, you said many times that you knew what was happening in January, and you were getting the signals even before that. The audience does want to know, and we've heard that that's where things were starting, but everybody really wants to know how did this start, and does that become important to you in the job that you were doing for the state of California to know where it began in Wuhan and how and whatnot? Is that do you reflect on that anymore?
Sure, all the time. So I'll start off with this, that I am not one of the experts in the US that has access to privileged intelligence around that. There's really smart people working on COVID origins. I do understand that more is going to be revealed. Some stuff's been declassified and more probably will be. And I think that is good. I think shedding light on it is something we're all interested in learning more about. Here's what I'll say about January of 2020. When the threat of COVID was emerging and I was looking at scattered signals, what I would call, I'll use software language, third and fourth order proxy signals that are correlated loosely with what the threat is. And I'm talking about videos on social media of people being soldered into apartment buildings, the great lengths that Wuhan was going to quarantine and isolate, hospitals standing up over the weekend with bulldozers and tents, and then the very early reports from local journalism that this was possibly airborne, that there was spread between people and households and in a way that would suggest an airborne pathogen. In that moment, this is true for all outbreaks and biological threats. It does not matter if it came from a natural event, if it came from a lab event, if it was biologically engineered. In that moment, a disease controller has one goal: determine how many undetected cases are out there in the community or out there in the world for the purpose of containment. Containment has to be our first objective. Now, at the time, I thought we, the United States, may still have a shot at containment because at that time it wasn't clear the component of asymptomatic spread. In other words, it was everywhere, you guys. We just didn't know it yet. And so in that moment, what I was asking myself, with a strong suspicion that it likely came from the Wuhan Institute of Virology, but I didn't know, none of us knew. I was asking myself, what can California do? What can America do to contain this virus? Or have we lost a shot at containment? And now we're going to have to use broad measures that nobody wants to do. We are flying blind. And in rapid biological threat containment, that the biggest threat is flying blind. If you don't have testing, if you don't have visibility on how many cases are out there. So in January 2020, I was not doing a lot of mental gymnastics trying to figure out if it was, a nature spillover event or if it was a laboratory accident. I was scrambling to put together an operational response plan, I'd say for California, but it was really for the United States of America. Do I care about COVID origins? Absolutely. And I look forward to learning more. And I think all of us doctors and scientists are interested in them. It's super darn relevant to what I'm doing today. because the work that we do and that we're focused on includes biologically engineered pathogens that may be natural but are in a BSL-3 or BSL-4 lab where an accident could happen, stuff that is more than just a natural evolution from Mother Nature. And so that's why I watch with great interest.
A lot of the audience is interested in what you're now doing, biologic threats, spooky pathogens, avian flu. How should they be staying abreast of this information, or what should they be doing as medical practitioners, rheumatologists, and advanced practice providers?
Mm-hmm. So here's what I'll say about H5N1. The first thing is some very good news for us, for the physician community, broke yesterday. And that is Dr. Jerry Parker was just appointed on the National Security Council to the role that Dr. Paul Friedrichs was in. So this was head of the Office of Pandemic Preparedness and Response under the Biden administration. There were questions of whether or not the Trump administration would keep that office. If you don't know who Jerry Parker is, he's a veterinarian. His focus is on One Health. He is a doctor's doctor, nonpartisan, very seasoned in this area. And that is a good sign because the continued focus and collaboration from the national security level is exactly what needs to happen for H5N1. It would be impossible to lead this from a division like CDC or even one agency like Health and Human Services, because it cross-cuts, Department of Agriculture and so many other considerations. So good news is a veterinarian specializing in zoonotic disease is now in charge for the country. The challenging news is, and we are following this along with everyone, the ongoing risk of human-to-human transmission and the concerning reports that we're seeing out of different states. I know that there now may be evidence of household cat-to-human or human-to-cat transmission. Waiting to hear more information about that. We are watching that closely, but I'll tell you this, that H5N1, as worrisome as it is and as focused as those of us in this field should be on monitoring for human-to-human transmission, this is one of many new threats that we're going to see. The landscape has changed, and the heightened concern for biological threats. I know because I work with big companies like Google and Target. They are very interested in following this. There's a new level of concern from businesses, from corporations that we didn't see before COVID, and you could call that a silver lining to COVID. That the great U.S. companies that really hold up our economy and, supply chains and manufacturing, there is a heightened interest in biological threats. There is a heightened understanding that communicable disease plays a massive role in business continuity and health. I just didn't see that before 2019. And so I think there's some silver linings to what we went through in COVID. One of them is the infrastructure that's been set up, for Office of Pandemic Preparedness and Response out of the White House that very clearly the new administration is going to prioritize. That's not a political statement. That is just true. That I'm excited to see. I'm excited to see Dr. Parker coming in and how seriously they're taking it. And the human-to-human spread, we all know that's what we're watching for.
So we have a few more questions. One, you made a strong call for us to reframe our thinking on AI, where most people are suspicious, want to avoid it, whatever. You're saying do the exact opposite. So what is the call to action? How should the average rheumatologist be in getting more familiar with this? Just use it as much as possible? Or, what's your advice over a dinner table with other doctors?
Well, just between us friends, first of all, rheumatologists are a different breed of doctor in terms of thinking about systems of systems. And so I would say, out of all the docs, rheumatologists and surgeons, because of anatomy, are just the best position to dig in. What would that look like? Begin using the tooling that's out there, whether that's starting with ChatGPT. There's a lot of really cool AI tools that are pretty basic that you can just get started with, of leveraging a large language model to write an email, to start a presentation, to start a white paper. Once you start familiarizing yourself with it and those really basic tools that you can buy online for very, very cheap, less than $20 a month, you realize that how malleable they are. that it's just a set of rules, a rule set in the background and algorithms that have been trained by a corpus of data. It's no different than the way that we are trained to think as clinicians. And once you start using those tools for something dumb like writing emails, you realize that they're not intimidating at all, and you start to understand how they are developed. I'll put a shout out for the startup ecosystem. That if you as a rheumatologist have an opportunity to get involved with any of the med tech, health tech, biotech companies that are developing machine learning or artificial intelligence in your space, do it. They need you as an advisor. They need your wisdom. They need your maturity. They need your experience over the years. Because again, God bless 22-year-old software engineers, but they need the leadership of doctors in this space. You do not have to learn how to code. You don't have to go, learn all the complexities of the math behind it. What they really need more than anything is your leadership and your wisdom. And so the startups is a great place to get involved. There's a lot of advisory roles. You can look it up online or look on LinkedIn, or some of the venture capital firms that are in the biotech space are always looking for seasoned, trained physicians as advisors to these really young, really smart, but totally inexperienced teams.
Charity, in your keynote address, you said that your focus in public health was on the patient, the community, but also even beyond that in the nation. We don't think that way when we're seeing patients day to day. Should we be thinking that big?
Mm-hmm. Well, this is why I honestly, if you slice me open, I'm a doctor at my core. Today I'm a defense tech CEO, but I'm a doctor at my core. And this is why I say a doctor's thinking is what I'm leading with as we build out our tooling. In residency, I treated patients one by one. And when I became a local health officer, I was responsible for a county of about 460,000 people. And that population was my patient. And so I would make a differential diagnosis for the population based on symptoms that I was seeing of the population and make a treatment plan for the population. When I became state health officer for California, I was initially really intimidated because it's 40 million people, but I quickly figured out it's no different. Now my patient was California, and the symptoms you watch for are the scattered pieces of data, the scattered signals, third and fourth order proxy signals, indicating where do we have a threat, what direction is it headed, and how bad is it going to get. And it's no different for the nation. Now we're up to 340 million people. But that lens of a physician, the differential diagnosis and evaluating each symptom or each clue, and then following the shrewd instinct of what direction that disease is headed. How bad is it? How far is it going to go? How fast? That's still what I do today. And you know who taught me to do that? First, it was Norm McSwain. I was general surgery and obsessed with trauma at Charity Hospital. And so I used all my rotations to work with Norm McSwain in the trauma bay and Steve Jose in Santa Barbara. And so the great physician leaders that trained me, that's what I'm referring to, that experience and muscle memory is simply just applied to a population level. And yes, that's why I would love to see more doctors get involved in population, public health, and kind of that large landscape management of risk. There aren't enough docs in it.
Dr. Dean, we want to thank you for sharing your story and opening up to us. This has been very enlightening. Thank you.
You're welcome. My pleasure.
Okay.